the interesting piece is that intraoperative mortality is next to negligible. We are now operating on patients who are older, who are sicker, and who have more complex comorbidities as they come into a surgical operation in an operating room. Yet, patients do not do well in the first 30 days after non-cardiac surgery. In fact, if the 30 days after non-cardiac surgery was taken as a disease entity in and of itself, it would be the third most common cause of mortality in the United States of America, only after diseases of the heart and malignant neoplasms. That tells you that patients do well inside the operating room, where surgeons are operating on them and anesthesiologists are taking care of them. However, when they leave the four walls of the operating room and come to the post-anesthesia care unit, the perioperative environment, and the general care floor, that is where things start going wrong. If we look at why patients don't do well post-operatively, there's 3 or 4 important reasons. There's infection, there's bleeding, and then there's myocardial injury after non-cardiac surgery. We cannot control a lot of post-operative bleeding. Some patients, by virtue of their operation and their medical conditions, are likely to bleed. We cannot control a lot of infections post-operatively. Again, by virtue of their surgical conditions, some patients are likely to have infections. What we can control is myocardial injury after non-cardiac surgery. Data has shown that this entity, also called MINS, is very strongly associated with post-operative and intraoperative hypotension. During surgery, we have all eyes on the patient. We have continuous monitoring. We can see hypotension as it happens and correct for it. Once the same patient comes out of surgery, and is in the PACU and then goes to the general care floor, then we switch to intermittent monitoring again. With intermittent monitoring, we miss a lot of post-operative hypotension. Myocardial injury is dangerous. Not only is it associated with hypotension, it is silent, which means patients do not experience any chest pain. All that really happens is an increase in something called serum troponins, and it is not troponitis, it is myocardial injury. This myocardial injury is associated with significant mortality in the 30 days and in a year after non-cardiac surgery. So all put together, continuous beat-to-beat hemodynamic monitoring is the answer. If we have to really see how our patients' hemodynamics are behaving in the PACU and on the general care floor, and if we're going to correct for one of the biggest killers in the post-operative period, which is myocardial injury after non-cardiac surgery.